I'm oral historian Mike Chappell. Today, June 24th, 2012, I'm interviewing Dr. Roger Unger for the Endocrine Society at its annual meeting being held this year at the George R. Brown Convention Center in Houston, Texas. Dr. Unger, what enticed you to enter a career in medicine?
Well, I wouldn't call it enticement. Everybody in my family was a doctor, my father and his brothers. And so it was the path of least resistance for me. Before I knew it, I found myself in medical school.
Why did you choose to attend Yale University?
Well, I always, as a child, been fond of Yale for non-academic reasons, and decided if they would accept me, I'd go.
And how were you supported?
Pardon?
How were you supported at Yale?
By my, you mean financially?
Yeah.
By my parents.
And what was university life like at Yale in the
Well, it was kind of hectic because the war had begun. I started in 1941, which is when Pearl Harbor was attacked. So we were accelerated and had nonstop education, no summer vacations. And I got my degree very quickly before going to medical school.
And then you went into the Army after that?
Well, yeah, I went directly into the Army. The Army then sent me to the medical school.
And why did you choose the College of Physicians and Surgeons at Columbia?
Well, it was an outstanding institution. My father and his brothers had gone there as well.
And how did you first become interested in research?
Well, I wasn't first interested in research. I went into practice in New York, and I had a number of type 1 diabetic patients, and I had a couple of hunches about the mechanism of some of the abnormalities that they exhibit, and specifically that hyperglucagonemia was probably a major factor in the abnormal glucose homeostasis that these patients suffer from. And I wanted to test that hypothesis, and I tried to do it in New York City at the medical school in which I was affiliated, but they were not very enthusiastic about allowing a private practitioner to do research in the institution. And I happen to have some friends at the University of Texas Southwestern Medical School in Dallas that I had met when I was stationed there in the service, and they were very willing to let me come there and do the work. So I thought I'd go down and do the research for a couple of years, then return to New York. Well, I still haven't returned to New York. It's been a while since I moved there in 1959.
Now, before you set up your private practice in New York, you were in the public health service.
Yeah, that's when I spent some time in Dallas.
And is that when you first got interested in diabetes then?
No, it was after I was in practice.
Okay. Let's see. Well, I want to ask you a little bit about the
I mean, I was interested in it, but I didn't have a specific. When I was in Dallas, I was working in a diabetes detection unit. Not out of interest, but that's where I was assigned.
Mm-hmm. And what were you doing specifically?
We were screening the population of Dallas for diabetics.
And what was the state of the art in diagnosis when you were in Dallas?
It was, in my view, incorrect. And one of the things that came out of the study was a fuller understanding of the diagnostic criteria. Give you an example, the standards that were being used to make the diagnosis of diabetes were present in 50% of the patients that we screened. So we knew that either those criteria were wrong or Dallas had an epidemic of diabetes, the likes of which had never been known to exist. So as a result of those findings, the criteria of the American Diabetes Association were modified to provide a more realistic detection level.
Was that the intravenous tolbutamide test?
No, that was, this was the oral glucose tolerance test.
Oh, okay. And then you instituted the other, the tolbutamide test?
Well, that was just a minor study we did at the time. That was never an accepted diagnostic tool.
When you returned to Dallas and the University of Texas Southwestern Medical School, what work did you begin working on?
Well, since, as I mentioned earlier, we were interested in elucidating the role of hyperglucagonemia in the pathogenesis of diabetes. But at the time, there was no way to measure glucagon or any other peptide hormone. The insulin assay had not yet been developed. And I had the idea of a competitive immunoassay for glucagon. And I thought that if I could learn to iodinate glucagon, we could make such an assay for glucagon, and for that matter, insulin and any peptide hormone. Now, at that time, the iodination of peptide hormones was pretty much the work of Saul Burson at the Bronx VA hospital. So I called him up and asked if he would teach us how to iodinate glucagon. And he asked why I wanted to know that. And I told him it was for radio immunoassay. And he said, "What was your name again?" And I told him. And he said, "Where are you located?" I said, "Dallas." He said, "Can you come to New York?" And I said, "Sure." And I went up to New York, and then I found out what the problem was. He had already developed a radio immunoassay for insulin, and he thought I was about to steal it. So I congratulated him and told him, "No, I'm really focusing on glucagon. If I can iodinate glucagon, I'll be able to do a glucagon assay." He said, "Well, lots of luck. We've tried it for years and we can't get it to work." Now, at that point, we had already immunized a large number of rabbits with glucagon. So I said, "Well, listen, teach me how to do the iodination, and I'll go back and screen the rabbits to see if we have any glucagon antibodies." So he taught me how to do that, and I went back and we found some glucagon antibodies. And within 3 months we had a glucagon assay. And he was remarkably generous for a scientist. I showed him the results, And he said, you have to write this up right away. This is a major breakthrough. And I said, well, but when is your insulin assay? That has priority. I don't want to send my thing in until after yours is published. He said, don't worry about me. Go publish your own.
Wow.
And in the article, you can mention my contribution in the bibliography. Well, I did that, and I thought that was a unique gesture of generosity. I later nominated him for the Nobel Prize, but he died before he could get it. But his partner got the prize a few years later.
Now, you said you had when you were in private practice, you had a hunch about glucagon. I was wondering, what was the status of glucagon right when you began entering the field?
Well, I don't know if you know the story of the discovery of insulin. It's a very complicated story, but to make a long story short, Banning and Best at the University of Toronto got the credit. And what they had done is they took extract of dog pancreas and injected it into a diabetic dog and watched the blood glucose. Now, the first few minutes after the injection, blood glucose went up, but later it went down, which is what they were looking for. They ignored this initial upward blip. Understandably, they were trying to cure the diabetes or ameliorate the diabetes, and this was making it worse. 1 year later, two scientists in Chicago called Merlin and Kimball isolated that early part of the glucose curve. They separated it from the insulin, and they named it Glucagon. And it was considered a contaminant, not a hormone, contaminant of the insulin extract. The whole world was so excited by the insulin, they didn't care about the glucagon. And for about 20 years, it was ignored. And we came along and got the glucagon assay. We're able to prove that it is a very active hormone, that it is increased in every form of diabetes, including total pancreatectomy, which doesn't remove all the alpha cells. There are alpha cells in the stomach that produce glucagon after you remove the pancreas. So that there's no such thing as diabetes without glucagon. And insulin alone prevents death from diabetic ketoacidosis. But no matter how you manipulate the insulin levels, you can't restore normal glucose regulation. Or you're not a diabetic, are you?
No.
Okay. So if we gave you a one of those big soft drinks that Bloomberg has outlawed in New York City, and you drank it down as fast as you could, your glucose probably wouldn't go up more than 5 or 10 or 15 milligrams percent, while in a diabetic it would go up to 500 or 600. Also, if you stop eating for a couple of days, your blood glucose will drop maybe to 55 or 50. In a diabetic, it might drop to 20, and he might die of hypoglycemia. So, in other words, even the best controlled diabetics don't come anywhere near to restricting the movement of their glucose levels the way a non-diabetic will. And we wondered what the reason was. And recent studies that I presented today, actually, have given the answer. We know that, hard to show this without slides, but inside the islets of Langerhans, you have in every glucagon-producing cell and every insulin-producing cell in juxtaposition. And insulin suppresses glucagon and senses the glucose level. So insulin will respond to a rise or a fall of glucose by controlling the glucagon level. So together, they release a mixture of insulin and glucagon that oppose each other's action on the liver that's appropriate for the glucose level. In a type 1 diabetic, you have no beta cells in the islets. The only insulin that's available to the alpha cells is what you inject. Now, there's no way on God's earth that you can inject enough insulin to match what's locally secreted by beta cells that are right next to the alpha cell. These alpha cells are going to get probably more than 100 times as much insulin as they will get from a peripheral injection. So we thought that was the reason for the roller coaster behavior of the glucose levels. And when we suppressed the glucagon level, the roller coaster became flatter, no matter how we suppressed it. So we decided that the way to improve the treatment of type 1 diabetes is to reduce the insulin levels to physiologic levels so you no longer get hypoglycemia. That's going to let the glucagon go higher and make the hyperglycemia worse. So you have to suppress the glucagon with something other than insulin. When you do that, you get a perfectly flat glucose curve. And that's what I presented today.
Now, when did you have that idea, that concept of adding in the glucagon with the insulin? When did you first begin to think that that might be the way to go?
Well, I began to think of it in normal physiology when I first started. I didn't realize it was going to be so important in diabetes. And it was only after we worked out the normal physiology of glucagon, which was in the early 60s, that we turned to diabetes. And because we didn't know before, at that time, it was elevated in every form of diabetes. And the actions of glucagon, if you infuse large amounts of glucagon, what you see is exactly what happens in diabetes. So you can produce a facsimile of the disease by overtreating with glucagon. So it all added up. There was no piece of evidence that argued against it. And whenever you're unable to disprove your own hypothesis, that's a very encouraging sign.
Now, you've been at this for, I guess, 5 decades.
A couple of years.
But you took a hiatus from the end of the 80s, I guess, to the present. Not the present, but say the last 80.
From the glucagon story.
Yes. What happened there?
Well, what happened was this. We published a paper in 1978 in a New England journal in which we proved the hypothesis that I just told you, that reducing the insulin and suppressing with something other than insulin, suppressing glucagon, would normalize the glucose. The problem is, after 4 days of what we used was somatostatin, which Roger Guillemin's group had discovered in 1972. Another group showed that it could suppress glucagon. And when we learned that, we decided to treat diabetics with low insulin levels and adding somatostatin. And it worked like a charm. But after the 4th day of treatment, they developed side effects that precluded continued use of somatostatin. So we quit, and there was nothing else we could turn to at the time. So we moved on to other areas, and
Did you consider other things to try, or there was just
nothing
impossible?
to try? Yeah, of course. We were searching. There was nothing that. Remember, in those days, technology was not what it is today, and many of the molecules that we use today were not known to exist back then. So today we have about 10 or 15 glucagon suppressors. Somatostatin was the only one back in those days. In 1994, at Rockefeller University, Jeff Friedman discovered leptin. And we began studying leptin. And then, by an accident of fate, for reasons that had nothing to do with the treatment of type 1 diabetes, we injected an adenovirus containing the leptin cDNA into a severely ill type 1 diabetic who was almost ready to die. And unless we gave him insulin. But the animal, after the injection with the leptin-containing virus, became normal, as if we'd given him insulin. And we looked at the blood to see if there was any insulin. There was none. The animal has absolutely no insulin, and yet he was thriving. So we repeated this several times, switched back to the original study that had been suspended for 30 years. And to our amazement, we couldn't believe this, because we had all been trained to believe that life without insulin is not possible. And there was no insulin in these animals. They thrived with no treatment for almost a year. So this was with adenovirally delivered leptin. We repeated it with infusion of the leptin protein. We got the same results. And we found that leptin was a much better suppressor of glucagon than somatostatin. Didn't have the side effects. Now, since the leptin study, we've identified 9 or 10 other hormones that do the same thing. Some as good as leptin, some not as good. And the most exciting thing is that there may now be on the horizon, thanks to work being conducted by 2 of our collaborators at UT Southwestern, Mike Roth and Matt Evans, that an orally administrable glucagon suppressor is a possibility. In fact, there's one out there now studied at the University of Toronto by Dr. Wang. It's gamma-amino butyric acid, a neurotransmitter. It can be given by mouth, and it suppresses glucagon and reduces the glucose levels in type 1 diabetic rodents. So we're very hopeful that a new era in the management of type 1 diabetes may be looming. I'm a little superstitious, and I don't want to jinx it with any further predictions. The same role for glucagon can be invoked in type 2 diabetes, which is 10 times as common as type 1, and afflicts a depressingly high percent of the American population. But this is obesity related. It can be reversed by a number of procedures. The most effective one is to sew up the lips and stop overeating, and then the disease recedes on its own. But I don't think that would be a popular option for most
Probably not.
people. But that is a different type of disease, much more harder to study because it evolves over decades. And just having that diagnosis doesn't indicate what stage of the disease you're in. Whereas with type 1 diabetes, there's an early phase during which the beta cells are destroyed. And after they're destroyed, everybody's the same. It's not going to change with time. So that's pretty much the direction of our research. During that 30-year hiatus, our lab focused on lipotoxicity, which is the American disease. It's the result of overnutrition and underexertion, and it involves the ectopic deposition of various lipid species in the tissues where they don't belong. The reason we have fat cells, adipocytes, is because the non-fat cells do not have the capacity to store large quantities of fuel to be redistributed during starvation. In other words, if the cells of the heart could store fat, you wouldn't need to have adipocytes, fat cells, but they can't. If they're overloaded with fat, they're destroyed. They don't function normally, and ultimately they undergo apoptosis and die. So the fat cell protects you from that. What's called the metabolic syndrome, which includes type 2 diabetes as well as high lipid levels, high blood pressure, fatty liver, fatty heart. That's all due to the failure of the overabundant lipids that have been put into the body to find a safe place in the fat cells. They're spilling over and injuring the other tissues. And this is now pretty well established as the mechanism for metabolic syndrome. I wouldn't call it non-controversial, but I think the opinion is leaning in that direction.
And is that the idea of the concept of the fatty heart that you're talking about?
Yes, it can be the fatty anything. The concept about obesity is a little, in my view, backwards. People think that obesity causes these diseases. In fact, obesity delays the onset of these diseases by storing the surplus calories in a tissue that can't be injured by fat. And only when that stops, when that process of expanding the adipocyte mass stops, and you continue to overeat, where are the calories going to go? If they're not going to go in the fat cells, they're going to go in the non-fat cells. That's all there is. They go in the non-fat cells, you've got a disease. So everybody says that obesity is a disease. No, that's the normal response to overnutrition. The disease begins when the excess calories spill out and don't get in the adipocytes. Now, some people have what's called lipodystrophy. They have no fat cells at all, no place to store surplus calories. They also have a very big appetite. They get all of these diseases that we see in middle age and later. They get it in childhood very, very severely, and they have a markedly diminished life expectancy unless they're treated. So I think we really have it put backwards. Most of the weight-reducing regimes succeed in lowering body weight by maybe 10, 12 pounds, And then that plateau is reached, and there's no further weight loss. And the patient is devastated because the patient thought she was going to become a fashion model. What she's done is she's lost fat, not from her fat cells, but from the non-fat cells, because the first way to go when you restrict your diet is the ectopic lipids that are in the heart and the liver. And so basically, she got healthier, but she didn't get any prettier. And I would have thought that these weight-reducing companies should be marketing the health benefits rather than cosmetic benefits. Because once you're obese, you're never going to be a fashion model. There's not going to be any treatment that can overcome real obesity.
But I thought you said that if you sew up the lips, that would take care of it. Is there a certain point that if you just stop eating, you're going to lose?
Well, the reason we have adipocytes is starvation. Throughout evolution, starvation was the main evolutionary hurdle for every species. So in order to survive, a species had to find a way to cope with starvation. Mammals developed adipocytes, and during abundance of food, they can store the calories to get them through a drought, a period of famine. And there are some animals like the desert rat. There's a rainy season during which there's a lot of food to eat, and the rat gets massively obese. And then there's a dry season where there is no food. Well, they have just enough fat cells to get them through that dry season. If it lasts a little longer, they're in trouble. But this is the way we evolved, and we're here, so it must have worked. Now, there is no real evolutionary defense against overeating because overnutrition was never a health problem during the 2.5 million years of evolution. It became a health problem about 120 years ago, and we don't know how to cope with it.
Now, does the desert, you said the desert rat, that's the animal you said that has that long dry season that it builds up the fat. Does that animal get thin?
It's skinny.
It could become a fashion model.
Becomes a fashion model. Yeah, starvation can make you a fashion. Well, I don't think a human. Do you know what an obese human looks like?
A severely obese. Yeah.
I mean, I've seen bariatric surgery where they're trying to find the stomach, and the fat of the arm of the surgeon is covered with fat. Now, you deplete all that fat from that. What happens to that tissue mass that's left over when the fat is out? I think you've taken 30, 40 years to build up that massive amount of fat. I don't see how you can ever recover from that. Your body is encased in
I see.
a wrapping that can be modified but not eliminated. It's a very bad disease. Hard as it is to treat, it's relatively easy to prevent. And I think that's where the focus should be. I think we have to give up on the current generations that have become obese and focus on preventing this from happening again. And the burden of that is being put on the physicians and the patients rather than the only people who can really control it, namely the politicians. I think if the politicians had the guts to do what Bloomberg did in New York and price obesity out of the market, or at least move in that direction, it would cut down on obesity the way they did with tobacco. it's nothing that the pharmaceutical companies or the physicians can really handle on their own.
How did you come to focus on the enteroinsular axis?
Which axis?
Enteroinsular, am I pronouncing that correctly?
Oh, well, we knew that there were gastrointestinal hormones that are released when a meal comes in. And we also knew that by measuring insulin levels during a meal, that the insulin rose before the glucose had left the intestine. That is, it wasn't the glucose that was doing the initial stimulation of insulin. Something else was signaling insulin that glucose had entered the gut and was about to come in. So we measured the hormones that were secreted by the gut and found indeed that they did rise as glucose was beginning to rise. And we also infused those hormones and found they stimulated insulin. So that we reasoned that the way a normal person handles a glucose load that's coming in is first there are signals that leave the intestine even before the glucose is beginning to enter the blood to warn the beta cells that they better get ready, there's a big load of glucose on its way. So rev up the insulin secreting machinery and get ready to meet the challenge of the glucose wave. And that's a relatively minor issue, but it made some teleologic sense.
On your glucagon work, I don't know if you want to divide it into the different periods that you did it, but would you tell me some of the key collaborators that you worked with or continue to work with?
The morphology throughout my career, Lelio Orci at the University of Geneva.
Excuse me, I didn't hear.
His name is Orci, O-R-C-I.
Oh, okay.
He's an Italian whose career was in Geneva. And he's probably the leading islet morphologist that I guess ever, certainly during my lifetime. And he collaborated with us extensively. Other than Orci, I've had no real consistent collaborator. I've collaborated with different people for different projects. But Orci has been the only steady one.
You mentioned that there were another series of hormones that, or actually, I think you said it would be hormones that would suppress glucagon. What are those other ones besides GABA and leptin?
GABA isn't a hormone, it's a neurotransmitter. All the others are protein hormones. The most recent one is fibroblast growth factor 21, FGF21. That looks very promising. Then there's the analogs of GLP-1, which include exenatide and liraglutide. And a weak suppressor is the hormone amylin, and its analog pramlintide. A German group has reported that orexin A suppresses glucagon. So it's a growing family. And I've been mystified by the fact that it took us 30 years to discover between somatostatin and leptin. And it's only taken 4 years to find 9 or 10 new suppressors, and new ones are coming on the scene all the time. I think that's in part due to the fact that these weren't discovered until about 10 years ago. We didn't know they existed. But still, I think we're looking more carefully now than we did 10 years ago. I think the whole concept has gained momentum, and you're going to see a lot more action now than before.
You received the Endocrine Society's most prestigious award, the Koch Award, nearly 30 years ago. What's been the nature of your relationship with the Endocrine Society over the years?
Well, I'm not a big fan of meetings. I'm usually in the wrong, especially big meetings. I'm always in the wrong room. And quite frankly, traveling is not what it used to be when I was younger. Either the traveling has gotten less pleasant, or I've gotten less appreciative of the pleasures of travel. I don't find that they're tempting enough to spend all that money to go to a place to talk for 20 minutes. I drove down to Houston. It took 3.5 hours. I didn't go to the ADA in Philadelphia. I gave the talk over the phone. And it was, I know that meeting organizers are not going to like what I'm about to say, and certainly the airlines and hotels won't. But I really don't see that shipping people all over the world for a 20-minute talk makes a lot of sense when you can do it almost free of charge by modern technology. I mean, unless you want to get out of town and really.
Well, you did give a talk today, though, right?
I did.
Yeah. How did that go for you?
It went very well. I have a lot of very nice comments.
One final.
In other words, I'm glad I came.
Now, you said you don't want to jinx it, but what are your current?
I don't like to predict marvelous results.
Mm-hmm. Well, here, let me rephrase it. The idea of treating diabetes with not just insulin, but with
that principle
bihormonal.
I think that principle is now proven. What I presented today was, what's your background?
I'm a historian, so I study
You have no
endocrinology. I'm not a scientist, no.
Okay. But you know about receptors and...
Yes, yes.
Okay. All of the glucagon suppressors that we've been talking about have other anti-diabetic effects unrelated to glucagon. So that every time you come up with a new one, somebody says, well, how do you know it's due to the glucagon suppression? Maybe it's due to this other anti-diabetic effect. And of course, there's no way to argue against that, except that it happens, and there are now 10 of them, and they all suppress glucagon. And if you replace the suppressed glucagon by infusing glucagon, you don't get the same response. nevertheless, we wanted an unambiguous way of testing the hypothesis that you have to have glucagon in order to have diabetes. So what we did...
So that, excuse me, that changes the whole perception of how...
I hope it will, but the human mind is not easy to change.
But I mean, the theory would change the whole thing.
Right, but the theory that the sun, not the earth, is the center of the solar system was put forward in, I think, 1463 by Copernicus and then Galileo. Galileo was sentenced to life imprisonment for heresy, and he wasn't pardoned until 2 years after the Hubble telescope was in place. That shows you how the human mind works. So I have no illusions that people are going to jump off the insulin bandwagon.
Okay, I'm sorry.
Anyway, what we did was this. We got some mice from Marine Sharon in New York, mice that had no glucagon receptors at all. And we took those mice and we destroyed all the beta cells. So they now had zero insulin, and they had no glucagon action because there were no receptors. They did not get diabetes. The control animals with glucagon receptors were dying in diabetic ketoacidosis. These were perfectly normal. So then what we did, we injected an adenovirus containing the glucagon receptor cDNA. It goes to the liver, and the liver now has glucagon receptors. When the glucagon receptors appeared, these animals got very sick with severe diabetes. But that transgenic glucagon receptor that we injected only lasted about 6 days. So we have a spontaneous way. We don't have to give them any ambiguous hormone. We just wait until the glucagon receptor disappears from the liver. When it did, the diabetes was gone.
They recovered?
They were normal again. Mm-hmm. So in other words, with no glucagon action, couldn't make them diabetic, even though there was no insulin. With glucagon receptors, they got very sick. When those disappeared, they were well again.
Wow.
So I think that there's no argument against the conclusion of that experiment. And I'm hoping that will galvanize these companies to move forward in this direction. But from past experience, it'll take a long, long time.
Mm-hmm. What's your next move?
Well, we're moving into type 2 diabetes. And we have, and the way we're doing that is we're taking the glucagon receptor knockout mice, but instead of destroying the beta cells, like I told you a minute ago, to produce type 1 diabetes, we're bombarding them with food to make them obese, and see if they can get type 2 diabetes in the absence of any glucagon action. And if they can't, which is what we predict, we'll then give them the glucagon receptor and expect to see diabetes appear very transiently until the receptor disappears.
Now, are you collaborating on this phase of your research with other people besides Orchi?
Yes, we're collaborating with 2 individuals at our institution who have set up a high throughput assay for glucagon suppressing drugs. And they're specifically looking for orally effective agents to treat type 1 diabetes by suppressing glucagon. Because what our work showed is you can't have diabetes without glucagon.
And type 2?
I think the same holds true to type 2, But type 2 is a messier disease to study because it takes, in humans, it takes decades to evolve. Even in rodents, it takes several months to evolve. And depending on what stage you deal with, you've got pretty differing clinical variables. So depending on how you select your animals or patients, that will influence the results you get. Whereas in type 1 diabetes, you either have it or you don't.
So I guess this is a pretty exciting time for you, and it must be, it motivated you to do something you don't like to do, which is to travel.
Yeah, you might say that. I used to be a big traveler. I don't know. I guess it's either age or, but I'm not a big fan of taking off my shoes in the airport, so.
Okay. Thank you for your time.
Thank you.